Good morning, everyone. My name is Dr. Aziz Seixas, chair in the Department of Informatics and Health Data Science, and I'm very delighted to welcome you to the U, particularly to the Future of Health Data Innovation, an incredible monthly series where we are trying to get the best minds, thought leaders, and action leaders to share with us how we are actually going to be innovating around data and how is it that we can translate data into greater insights. Our department is very unique. We are verticalized across 5 areas: education, research, clinical care, venture and service, and outreach. And I'm extremely honored and very delighted to have a phenomenal team, Alex and Dr. Mairead Maloney, as well as Loranda, and so many who are nameless but are working behind the scenes, who have put together yet again another fantastic installment. And so, with that, I'd love to welcome you, but also welcome my angel in destiny, Dr. Mairead Maloney, to welcome our phenomenal speaker for today. Thank you, Mairead.
Thank you so much, Dr. Seixas. I am Dr. Mairead Maloney, and we are so delighted and thrilled to have with us Dr. Hendricks-Sturrup today. She is the Research Director of Real World Evidence, RWE, at the Duke-Margolis Institute for Health Policy in Washington, D.C. She strategically leads and manages the Institute's RWE Collaborative and the RWE Policy Research Portfolio and Education. As an engagement expert, biomedical researcher, bioethicist, and policy practitioner with over 18 years of experience, her work centers on addressing implementation, regulatory and ethical, legal, and social implications at the intersection of health policy and innovation. She presently partners with Duke University faculties, scholars, students, and external practicing experts to advance the Institute's biomedical innovation work. We are so, as I said, delighted and honored to have her give her talk today. So without further ado, Dr. Hendricks-Sturrup, I will let you take it away. Thank you so much for being here.
Wonderful. Thank you for having me, and I'm thrilled to be here. I go way back with the University of Miami Miller School of Medicine, and I just feel like the moment keeps coming full circle, and I am thrilled to be a part of that circle as it revolves. So, with that being said, I'm going to go ahead and kick us off with my talk for today. So. Sorry, one second as I work through my own technical issues here. So today I'm thrilled to share with you all some work that I've done over the past several years that is essentially focused on the title that you see here. And I want to take a pause for a second just to make sure everyone can see my screen in full screen mode. That's correct? Okay. All right, I have multiple screens, and so sometimes it
Dr.
does.
Hendricks, we're actually seeing it not in presentation mode, or at least I'm not seeing it in presentation mode.
Okay, that's strange because it's showing in presentation mode on another screen of mine. So bear with me one second. I'm not sure why it's doing that. I have 2 screens and it's showing in presentation mode on my larger screen, I guess not my smaller one. All right, we'll try again.
I'm afraid not.
Okay. Oh, no. Okay.
The one thing while we fix these things, I'll just share a little bit about Dr. Hendricks-Sturrup. She's actually part of our faculty here at the University of Miami because, we know that ethics is such an important role in this new era of AI and technology. And in fact, we go way back. I was trying to save the intro, Rachel, but we actually met each other when we were doing a phenomenal program called Aim Ahead, which is a large national project that tried to bring and to build AI capacity across underserved communities. So thank you so much. And I see that we have the full screen in effect and really excited to have you. So I just wanted to sneak that in while we were waiting on sorting out those. hopefully that will tee you up even more. Thank you.
Oh, absolutely. Yes. Another way that in which we go way back. So the work continues, I'm happy to say, and I'm glad to be here, and I'm glad to be a part of the Miller School of Medicine family again in a volunteer capacity. So yes, thank you. And again, it's always nice to come back home. I like to call it. So today I'm gonna chat with everyone and give a lecture on, again, what you see here, a privacy-centric and federated approach to machine learning for the collection and sharing of what's called patient-reported outcomes, or PROs, patient-reported outcomes data in genomic medicine research. So I know that's a mouthful, but it's okay. We'll slow down and we'll take it from there. We'll take it slow. So today we are going to embark on these learning objectives. We're going to discuss the importance of collecting patient-reported outcomes, or PROs data, in genomic medicine research. We'll discuss clinical use cases and PRO data collection tools that have been used in this regard and in care settings. Describe a patient-facing, privacy-preserving, and machine learning-based mechanism that I actually published on about 5 years ago that can be used to facilitate the collection and sharing of sensitive PRO information. So thinking about this as a very privacy-preserving way of doing it to support genomic medicine research. So what are patient-reported outcomes? For those of you who are not familiar, they can be called PROs for short, or PROMs. Patient-reported outcome measures are what's called PROMs for short. And they are real-world data, or they can be a source of very rich, informative real-world data when it's collected in clinical care settings, or effectively not clinical trial settings. Real-world data is essentially data that is reflective of real-world phenomena versus controlled setting phenomena that you typically observe in your randomized controlled trial settings. And PROs can be useful to generate what's called real-world evidence. So taking all that real-world data, analyzing it in a very structured way to address a specific research question. PROs can be useful in that regard to become part of a total real-world evidence package, or a total evidentiary package reflective of the patient journey. And that could include, but not be limited to, the patient's diagnostic odyssey. That is essentially when a patient goes through a roundabout process for several months, all the way up to several years, to just get a formal diagnosis. PROs can vary in nature, largely via qualitative or quantitative means. They can be validated or unvalidated, and essentially collected in ways that I describe here via surveys. The survey itself can have structured fields that can be populated or answered by patients, or unstructured free text information within a survey, essentially asking the patient an open-ended question for them to answer. PROs can be collected through one-to-one interviews, focus groups, and documented even in electronic health records or other places as in the form of unstructured clinical notes. So here's a paper, and I will have some citations at the end of this lecture for you all to see. Here's a paper that outlines the main characteristics of patient-reported outcomes. And I'm sharing this with you all today just to kind of give you, again, a more illustrative overview of what PROs entail. So it comes in, PROs can be in various categories. The 5 are what you see here in the first column: health-related quality of life, functional status, symptoms and symptom burden, health behaviors, and patient experience. And why is all this important? Well, because typically in healthcare settings, we want to see improvement in a patient's ability to feel, function, and survive. And so PROs are a way of capturing that level of information from the patient's perspective, the patient's experience, versus from what an observer sees or interprets about that patient. And across all of these PRO categories, you can find strengths and limitations to that PRO category or approach. You can understand some of the main characteristics. For example, functional status is a very important one, whereas a patient can reflect on their ability to perform specific activities like going back to work, taking care of or maintaining their home, engaging in caregiver activities, those sorts of things. And And also patient experience is another really important example, such that patients can reflect on how they experienced a particular healthcare service or a therapy, a medication that they were prescribed. Again, each of these PRO categories come with their own main strengths and limitations. And we'll talk a little bit more about what that looks like today through a use case that I'll present. So moving into the use case. So first, let's talk about genomic medicine. So we can plug and play PROs into this equation. So genomic medicine, it's an emerging medical discipline that involves using genomic or genetic information about an individual as part of their clinical care. And that can be for purposes of making a diagnosis or reaching a conclusion around which therapeutic to prescribe that patient. And also, genomic medicine is important from a health outcomes research standpoint, as well as a policy implication standpoint as well, such that to the extent we can observe population level changes in health outcomes, what does that mean for policy, and how do we need to support or scale back genomic medicine interventions across various patient populations and subpopulations? Broad electronic health record capabilities that we have today allow us to capture structured genomic data or test results in the form of lab reports. We have that today. However, they are still emerging. And they're emerging in ways that really require people like you all and other interested and capable individuals to engage in thoughtful design and implementation around how we document this information in ways that allow clinicians to take action on a patient's care. So here is another table I'll share with you all. This was a systematic review that I actually conducted and published a few years ago, where I looked at three particular use cases. The first, breast and ovarian cancer syndrome; the second, Lynch syndrome; and third, familial hypercholesterolemia. These are three categories of disease that have been called Tier 1 genomic implications by the Center for Disease Control, and within the United States anyway. And essentially, what I did was I conducted a systematic review to see what has been reported in the literature around these three disease areas, these three disease focus areas, given their Tier 1 CDC status. What has been reported as far as individuals providing or sharing to or alongside researchers their concerns about how they feel, function, and survive with their condition, and in the presence of gaining information or knowledge about their genetic risk. And so we my research team and I found that three PRO types have been reported in the literature, with Kohler et al. Being one study that actually was a systematic review in and of itself. So researchers used validated patient-reported outcome measure surveys to examine psychological aspects, mood, emotional functions, or state within or among patients, knowledge and perceptions of their lifetime or immediate genetic risk of disease, coping mechanisms, social functioning support. All of this information has been gathered by researchers in a validated structured way via patient-reported outcome measure surveys, or PROM surveys, to my earlier acronym. And then also general surveys have been conducted. And general surveys have been used to determine how patients self-regulate and make decisions on the day-to-day, how much distress they experience, and how they perceive their own risks associated with knowing their risk of genetic disease for one of these three disease areas. And then also experience with satisfaction with the entire genetic testing process. General surveys have been able to capture that. And then qualitative interviews and focus groups have actually allowed researchers to capture more detail about how patients experience genetic testing for these three disease areas, and how they were able to act on those results. There was a major issue that came up, which is concern about insurance discrimination or stigmatization as well as concerns about cost of the testing itself and care afterwards. So sometimes just knowing your risk of genetic illness, sometimes just knowing that is not enough. It's about what am I going to do next, and what is the system going to do, and how is this system, if at all, prepared to assist me in this journey as I go about obtaining what I would feel is perhaps medically necessary care, what my doctor might feel is medically necessary care to manage my disease risk, and how do I go about navigating the potential for insurance discrimination along the way. All of these things are very important in the real world. And it's important for PROs to reflect that where patients report them. And then Kohler et al. Captured several within that systematic review, captured several or really 15 distinct elements of personal utility associated with genetic testing. And that involves broadly personal outcomes, essentially affective, cognitive, and behavioral outcomes, as well as social outcomes. Research altruism came up, whereas individuals felt, I want to engage in genomic research because I feel that there's a large public benefit to doing that. And so again, all of this displays the wide range in which individuals can perceive the utility of genetic testing for any of these three disease areas along their journey of obtaining patient care and engaging in research. So we're going to talk about a fourth use case now, transthyretin amyloidosis. It is a rare and often fatal disease caused by an insoluble fibril known as amyloid. There are over 30 precursor proteins known to date, and amyloidosis typically arises from misfolded transthyretin or immunoglobulin light chain aggregation. And that distinction actually plays a huge role in how patients are clinically managed as far as clinically managed in practice in the presence or absence of a molecular testing result. Transthyretin amyloidosis, or ATTR, is a type in which amyloid fibrils are produced due to precursor protein misfolding or precipitation in various tissues or organs that can be major organs like the heart, for example, causing organ damage or organ system failure even, whether cardiovascular or nervous system failure. And ATTR is, in fact, despite its risk, it's underrecognized and underdiagnosed and often fatal, unfortunately, for those who carry genetic risk. It does disproportionately affect individuals of African descent. So the African diasporas is particularly at risk of this form of hereditary ATTR. And so early clinical or molecular diagnosis is key to prolonging life or quality of life even. There is a certain genetic variation or variant associated with disease risk of hereditary ATTR, and that's the V122I or V142I coupled with phenotypic expression clinically. This is actually the specific variant that is tracked and traced in a molecular test setting to determine if individuals are in fact at risk genetically, and then couple that with information within their electronic health record as far as their symptoms that they are reporting or what their vital scans are showing, couple all of that together, and then suddenly you have a better idea of what's going on in that patient as far as their disease progression with hereditary ATTR. The most common mutation is the V122I allele, and it's present in around 3.4% of African Americans within the entire African diaspora. So that means an estimated 1.5 million individuals in the US are affected by hereditary ATTR. Here's a nice illustration to show where the origins of this exist within the African continent. So as I mentioned, ATTR, can be potentially fatal. And in fact, the cardiomyopathy form of ATTR is one of the most fatal because it affects the heart muscle, and therefore heart failure is common. A late diagnosis of ATTR cardiomyopathy, or CM, could mean having 2 to 3 years of remaining life expectancy. So prognosis is bleak, and the greatest frequency of of this V122I allele. It is present in countries along the coastal West African region. So you see a high allele frequency, or at least the highest allele frequency within areas of Guinea and the Ivory Coast, followed by others like Nigeria, Ghana, Burkina Faso, and Sierra Leone. So my team and I actually went about collecting patient stories reflecting those individuals' journeys, diagnostic journeys, individuals of African descent specifically, and how they went about navigating the health system to finally come to a conclusion that they are, in fact, or that they do, in fact, have hereditary ATTR. And so what we looked for in these stories, and we even conducted our own interviews to encourage patients to share their stories as well, in addition to sourcing stories found online. We identified some very important yet overlooked PRO themes, and that includes what you see here: access to clinical molecular diagnostic testing for TTR mutations. There's a general lack of access to testing. And so what that means is that clinicians are operating blindly in the absence of a molecular confirmatory test to essentially tell the clinician that this patient has a genetic risk. And so there's more to be done as far as working within the health system to help those patients manage their disease in the presence of previously unknown information that has something to do with what they're born with. Diagnosed populations might lose life insurance coverage, especially if they're molecularly diagnosed during late disease stages. So what does that mean? Families are affected in the event that individuals lose life insurance coverage because they have or come to know at some point throughout their life that they actually carry a high-risk variant for this illness. Life insurers, unfortunately, can discriminate on the basis of genetics. And so should a patient suddenly know or come to know information about their hereditary disease risk based on their genetics, and if they don't share that with the life insurance agency, there is a risk of losing coverage, and that affects their families down the line should the patients pass. Access to follow-up testing or care, which includes tissue biopsy, echocardiograms, radionuclide imaging, and other tests. In the presence of a positive result for a disease mutation or disease-related mutation, what does that mean as far as patients being able to qualify for coverage for or access to follow-up care? Is it affordable? Is it not affordable? And then also there's a lack of personal or family understanding of amyloidosis. So individuals who are biologically related, who come from the same gene pool, there's a lot of education that needs to happen within and amongst families who carry this disease risk. So that way they know down the line and today how to manage it and how to work through the health system to get their care needs met. So what I'm going to do is share with you all one patient story that was part of our assessment of a lot of patient stories. Her name is Cece, and she lives with hereditary ATTR. And this story was actually, it's found online via the Amyloidosis Research Consortium website.
I have hereditary amyloidosis. My mutation is V122I, which is quite common in the African American population. It has a 3 to 4% prevalence. And unfortunately, it's often misdiagnosed and underdiagnosed. It took a long time to get a diagnosis. My first symptoms were bilateral carpal tunnel syndrome. My next symptom was peripheral neuropathy, which was misdiagnosed as well. The next symptoms that developed was shortness of breath. I was feeling extremely tired. I was anxious. I was afraid. I knew that I was ill, and I had no idea what was really happening. I saw a pulmonologist, I saw a cardiologist, I saw a gastroenterologist, my primary care doctor, and a neurologist. So I saw 5 before I was diagnosed. I did not share my symptoms with the different doctors, unfortunately. In the medical system, it's the primary care provider that often refers you to all the specialists. And unfortunately, the specialists do not talk with each other. When I was initially given my diagnosis of amyloidosis, I was panicked. I was emotionally exhausted. There were times when I did not think I was going to make it through, but I did have a great deal of loving and caring people around me who helped me navigate this process. In order for you to be at risk of developing the disease, you only have to inherit the mutation from one parent, i.e. that means you can be heterozygous and be at risk for the disease. I, on the other hand, had the misfortune of inheriting this mutation from both my mother and my father. So both strands of my DNA have this mutation, which meant automatically my children had inherited the mutation from me. So my children are positive and are at risk for developing the disease. When I had a discussion with a cardiologist about my son with regard to having a genetic disorder, it never occurred to me that if you test for a genetic disorder and you have that, then there may be some possibility of you being excluded from healthcare, for certainly life insurance, but healthcare. When I was told I needed a heart transplant, I really could not believe it. I thought, no, there is another way. I was placed on the heart transplant the February 1st of 2012. On August 8th, I was called in the late afternoon, and I was told, we have a heart for you, and we need for you to be at the hospital in an hour. I couldn't believe it because I was dying. My skin was gray. My body was wasting. My brain was cloudy. My vision had changed. I had no taste in my mouth. I couldn't taste food. So yes, I was truly dying. And I had a transplant. I left the intensive care unit in 2 days, which was such an amazing thing. And I looked like a person again. My skin was no longer gray. It was the skin tone that I have now. I had color in my cheeks. I could think. It was amazing. It was an amazing experience. And I'm so grateful. I am so thankful. I was given the gift of this amazing heart. And it has provided me the opportunity to talk to people about hereditary amyloidosis, to help raise the awareness, especially in the African American community, about this disease. I feel wonderful. I feel like I have purpose, and that's important, and that moves you through when you have purpose.
So as you can see, we can learn a lot from patient stories. And here are a few key takeaways from Cece's story. It took her a long time to get diagnosed. In fact, she had several misdiagnoses along the way. She felt tired, anxious, afraid, panicked, emotionally exhausted, or stressed, and she knew she was ill. Yet she was referred to several specialists. She had to go through her primary care. The system shuffled her around before finally getting to the point where they can make a formal diagnosis. And compounding that issue was the fact that none of her specialists seemed to talk to each other, strangely. She had to communicate even with her family, especially her children, who, as she mentioned, are inherently at risk because they have inherited her mutation, considering her homozygous carrier status for the mutated or the mutation or affected variant. And so that there are implications for her children. I'm pretty sure there were implications for her parents had they been, if they're alive or had been alive. And she mentioned, again, the possibility of being excluded from healthcare and most certainly life insurance. She also described her clinical symptoms, which included brain fog, change in vision, loss of sense of taste, and just general malaise. And so again, we can learn a lot by just paying attention to the patient-reported outcomes. And we need to make it easy for patients to report these symptoms, these feelings, these concerns. Make it easy for them to share that with us so that we can make change at the system level. So here are a few key PRO-related themes from CC's story. She struggled to maintain an active lifestyle in later life. Her clinical signs tended to include a mixture of carpal tunnel syndrome, arrhythmia, gastrointestinal issues, and common signs of heart failure. The underdiagnosis of the disease generally in African American populations, again, results in late-stage diagnosis. We see poor outcomes, poor prognosis due to poor stabilization, and essentially preventative care early and often can make a difference. Yet our system is not set up to provide that. And our information exchanges within our health system is not clearly set up to do that either. Chronic, acute, and prolonged stress. She mentioned that. We said general malaise. It affected her day-to-day life functioning, and it increased her risk of mental illness as well, including depression, anxiety, and so forth. Our fragmented, under-resourced, and undereducated, and quite frankly, underprepared health system and healthcare providers contributed to her delayed diagnosis. So essentially, this tells us we can do much better. So we need to strengthen our patient-reported outcome collection tools, data collection tools to account for these patient stories. We need them to become refined even where they exist based on these patient stories. And so we evaluated several African descent patient stories online, as I mentioned earlier, including CC's, to summarize the underlying disease etiology faced by this specific patient subpopulation. We shared these stories to inform or enrich PRO themes that we know today that might convey the important spectrum of patient experience from onset to diagnosis to treatment and management, that entire spectrum. And lastly, inform efforts toward the development of data fields, data elements even, or features within electronic health record systems that might better align with these patient experiences and stories. So there are three tools used currently to quantify amyloidosis patient experiences. That is the PROMIS tool, the PRO CTCAC, and the ATTR QOL, or quality of life tools. Our assessment of these tools led us to determine that they must be refined to include domains reflective of patient journeys among the HTTR African descent patient population. So the theme domains that we found that are missing from these existing tools are themes related to access to molecular testing or genetic testing. Can patients even get testing in the first place? Will insurance be on board with it? Will there be access to insurance following testing? Will there be access to follow-up care in the event a patient reports a genetic test result, or in the event a patient reports inability to obtain follow-up care or testing? You know, what is the reason for that, and where can we identify certain patterns among patient subpopulations, patterns that tell us that the system is failing in more or less ways, or succeeding in more or less ways for certain patient subpopulations? Concern about late-stage diagnosis or poor symptom stabilization, and that's another key domain. And lastly, experiences involving that involve navigating complex health systems that contribute to delayed diagnosis. Sometimes it's not the case that the patient is not displaying the desired health behavior. Sometimes it's the system that's not displaying that. So how do we make that distinction based on what we can learn from patient-reported outcomes? So in a nutshell, developers, clinicians, researchers, we all need to come together to create and act on opportunities that allow us to identify and collect these patient stories so we can build relevant, reliable, and privacy-preserving electronic PRO capture systems. We need to leverage technology in meaningful ways, and one of the ways we can do that is by connecting our technology to the patient experience. So let's talk about artificial intelligence and machine learning, the fun part of why we're all here today. So AI and machine learning are transforming the way and speed at which we generate, collect, process, evaluate, and use real-world data to generate real-world evidence. That includes PRO data. Innovations include, but are not limited to, software instances, apps, and personal devices. We can apply large language models to process audio-visual data or machine-readable text for qualitative assessment. We can even use AI and machine learning to convert unstructured clinical data into structured forms for quantitative assessment. And then we can also power federated approaches to PRO data generation, distribution, and centralization. So we can do that. And then we also have regulatory backing and support for these things. For example, the US FDA released guidance not too long ago, final guidance, in fact, just in 2024 in July, on the use of real-world data, particularly assessing electronic health record and medical claims data to support regulatory decision-making. One of the AI machine learning focused guidance recommendations that stuck out here was that the FDA said that unstructured EHR data can offer important context into the patient journey and undergo conversion into structured, regulatory fit-for-purpose PRO data. That's essentially what they said in the screenshot here, where they talk about technological advances in AI to permit more rapid processing of unstructured electronic health data. So there are a lot of instances where PRO data is capturable within the electronic health record. So let's make sure that we can identify that, extract it in meaningful ways, and leverage our computer systems and to do the work for us, such that we're able to better qualify and quantify patient experience based on what's captured within the EHR. And we need to be able to educate providers on ways to do this, as well as educate developers on ways to embed those mechanisms within our electronic data capture systems. So back in 2020, I presented a paper at a major conference called ICML, where my colleagues and I discussed a federated approach to collecting patient-reported outcomes. And we did this in a way to highlight this approach as privacy-centric and also automated or automatable. So securing private user data, whether it's text or images, structured or unstructured data, throughout multiple steps of use, this can happen through PRO apps. And this presents interesting challenges and opportunities for app developers and system architects and programmers. Models can be either segmented or sent to users' devices for on-device training, or data can be encrypted, possibly aggregated, and sent to a centralized server. To use on-device learning, take a look at Figure 1. There must be the expectation that a user's device capacity will allow the transmission of model components and training of those components, as well as transmission of revised model gradients and model components by the device without significant costs to the users, like data use or app lags, those sorts of things. So we can allow patients or give them the tools that allow them to share this level of information with their health system, with their doctor, with researchers, so that we can begin to acquire the information about their stories, about their journeys in ways that are meaningful and actionable within the health system. So that way we don't sacrifice we don't sacrifice the lack of knowing, or we don't sacrifice what we can learn rather from patients along their diagnostic odysseys. And we can leverage AI to promote this information exchange in ways that help bridge divides between specialists that care for the same patient and that ultimately should be working together in order to properly diagnose the patient and gather information that's needed to ensure that that patient has access to care following before and after genetic testing to confirm hereditary disease risk. So in summary, before we move into questions, PROs and PROMs hold robust utility when they offer critical context reflective of the patient journey. That includes managing patients with hereditary disease risk. This is a prime example and use case. AI machine learning can be leveraged and can transform the way and speed at which we generate, collect, process, evaluate, and use PROs. We can structure or we can process unstructured clinical notes to populate PRO and PROM fields. We can power federated approaches to PRO data generation, distribution, and centralization for health system utilization and education and information. And also app developers, system architects, and others should collaborate with patients and clinicians, as well as health researchers, to design these privacy-preserving PRO data collection mechanisms. This can involve patients' personal devices. And this can also involve on-device training so that we can reduce the amount of patient burden that might be associated with reporting. And we can create decentralized data capture systems that can encrypt, aggregate, and send PRO data to centralized servers. Here is a list of references that everyone can refer to if you have access to the slides. And now stop there and open it up for questions. And I think we're right on time at 11:45, so thank you.
This is such an amazing presentation. I feel like I've learned a lot from you, and I'm going to go ahead and jump into the comments section and read you the first question that I see from Camille. Would sharing PROs across different EHRs be possible with this system if the patient is seeing specialists across different hospitals?
Yes, so I think that's a question around interoperability. Patients today have opportunities to leverage what's called a patient portal. And that patient portal may or may not be interoperable across multiple health systems or system providers. So it's really incumbent upon the health systems to come together with their providers and specialists to create some form of centralized mechanisms for patients to be able to upload their information or consent to sharing their information with certain specialists or providers or primary care clinicians. We really need to make it easy for patients to be able to do this. And one of the ways that can happen is by encouraging the use and adoption of interoperable systems across multiple providers. And we also need to, again, thinking about from a PRO standpoint, we need to create mechanisms for patients to have at their fingertips, a way to leverage their own personal devices, whether mobile or some other way, a trusted personal device to be able to quickly share that information and also easily share that information in a digestible format that can be actionable on the provider side.
Absolutely, absolutely. The next question is, how are these types of ML models audited to make sure the data we are getting is accurate?
That's a very good question. And quite frankly, we're still in the process of developing best practice solutions around that. It really depends on quite frankly, a number of factors. Obviously, AI machine learning can be a bit of a black box depending on how it's developed and implemented. But from a regulatory standpoint, auditability and traceability are key. In fact, they're required by statute. So to the extent that there are developers trying to, enable those forms of technology, it would be best for them to create systems that are auditable and traceable and inspection ready, quite frankly, so that regulators can meet their regulatory needs and goals and expectations, again, according to certain statutes, depending on the use case. But nonetheless, I think, again, developers need to embed within their systems way to sort of time, date, stamp things, figure out ways to track IP address information in a privacy preserving way. And also enable the appropriate consent mechanisms along the way and across the entire system pipeline.
So thank you so much. Related to these questions,
Mairead, can I just interject quickly, if that's okay? Dr. Hendricks-Sturrup, do you mind just discontinuing sharing your screen so that we could see you, if that's okay? Perfect. Thank you. Excellent.
No problem.
Sorry, go ahead, Dr. Malone.
I was just going to say, you've done an incredible job of outlining a number of barriers and also pathways forward. If you could wave a magic wand and implement one thing right now in terms of best practices to move this forward, what would that be?
Wow, that's a big question. I give these talks, from the perspective of not just, an academic or a policy practitioner, but also as a patient and as a caregiver. I think we've all witnessed more or less ways in which our system is kind of set up to fail. I think the system right now incentivizes speed at which, the system can see the most patients in the least amount of time. And so I think if I can wave a magic wand, I would say let's build on that knack for speed by leveraging AI machine learning in order to do the work. Like let's get all the information that we need, and let's leverage AI and machine learning to enable clinicians to have all the information that they need to make the right decision at the right time regarding patient care. Patients suffer a lot by just having a delayed diagnosis or delayed access to treatment, or having to navigate, transportation barriers to get to and from multiple providers, or to and from a pharmacy, or follow-up appointments. The system is not set up for a patient to be successful, even in the presence of desirable patient behaviors. So my magic wand would be to, make it easy for that to happen. Make it easy for providers to have all of the relevant information about a patient, such that, the patient can get, again, the right diagnosis at the right time. And they have all of the treatment options available to them at the right time in ways that are, and they have access to care without compromising the remainder of their livelihoods along the way, like access to insurance.
That's a wonderful answer. I love that answer, personally and professionally. Okay, the next question is, what can we do for patients with limited access to digital PRO assessment or limited digital literacy? That's a great question.
That is a great question. Again, I think, obviously, developers, they have a responsibility of making sure that whatever it is that they create, it has to be accessible to a target audience, and the health system itself needs to make access to those tools accessible for patients, especially if, I see a lot of times health systems engaging in conversations around behavioral economics, where they sometimes say that, patient outcomes are the result of patient choices. Okay, well, where can you make it easy for patients to make the right choice? And sometimes that might mean you providing patients with digital tools, or providing their caregivers with digital tools that enable them to make the right health choices, to make smart health decisions, and enabling technology that allows patients to, take their medicine on time, or access their prescriptions, on time every 30 days or 6 months, or whatever that might be. The system has to meet patients where they are. And sometimes that means the patient doesn't have access to the technology. So again, that's a system failure, not a patient failure. And so we need to account for that. And we need to find smart ways to invest in people's health, not invest in just showing up when they're sick.
Absolutely. That's an outstanding answer. And a great follow-up question to that is, have you been met with any patient or provider concern with integrating AI or machine learning given its relative novelty?
Honestly, I feel like, I see the entire spectrum, where, you have some providers that are very excited about what AI machine learning have to offer, especially with regard to processing prior authorizations, or gathering information that is needed to process prior authorizations on behalf of patients, where, they might not have a lot of time to gather all that information themselves. And so they might rely on an AI tool to immediately source that information by crawling through an EHR record for them. And then there's also, ambient charting that some clinicians, tend to rely on in order to capture patient information exchanged during a patient encounter in a very structured way. But then you have some clinicians who say, well, anytime I engage with any technology, whether it's an EHR or anything, it takes my focus away from the patient and it puts my focus on the computer. So again, I think it really depends on the provider readiness for all of that. And it really depends on how well the provider can balance the use of technology with patient connection in those moments. And I think there's a huge opportunity right now to educate providers on how to do that, how to leverage AI in a way that actually enhances your patient provider connection, not comes in between, not essentially thwarts it or interferes with it.
Outstanding. Thank you so much. We have one final question, and then I'm going to let Alex remind us of our CMA credit, and Dr. Seixas will take it on. If I'm interested in working in health informatics, do you know of any mock patient records or resources that I could use for independent projects? Wow, how interesting.
Oh, sorry, maybe I should read. I think the audio cut out for me a little bit, but oh, okay, I see the question here. Okay. Mock patient resources. I hate to sound like a broken record, but go look for patient stories online, like what I did, what I described. Use that as a source of information to create your own project and publish that, if you're able. There's so much information online. There's so much, and obviously look for reputable sources. Like this story was found through the Amyloidosis Research Consortium. There are other resources, patient story resources that can be found online. Look for those legitimate resources and just do the work yourself. You'd be surprised at what's out there and what people just simply haven't processed yet. Our study that we published on, patient stories to enrich existing PRO tools, that hasn't been done. No one did that. No one thought to say, oh, well, maybe I should just go listen to some patient stories and figure out how to do this better. Just go do that. Because quite frankly, if you're waiting for someone or if you're waiting for something to bring those resources to you, you really run the risk of missing what's already out there. So just go look for it, engage in the communities that are trying to create those resources. Mock patient records and resources exist out there in the form of open data, like the All of Us research program, for example. They have a data browser that has information that is very useful. In order to just, examine population level characteristics and phenomena with respect to genomic medicine or other aspects of medicine. So take advantage of open data, take advantage of content that's already online and see what's possible, see what it is you can find and what you can do and what insights you can glean and share with others from that information or based on that information.
Thank you so much. So Alex, if you want to remind folks real quick about how to get CME credit, and Dr. Seixas will bid us a closing.
Hey everyone, thanks again for coming. I am putting in the chat again the link for the CME credit. So you are going to click on that link and you will take you to a page where you may be asked to create an account, depending on whether you are an employee or not. There, you'll click on one of the two options. Then it should give you a activity ID. I apologize, the activity ID in the chat's probably out of date, but it should just populate the new activity ID. And all you'll have to do after that is click yes and then click claim credit. So if you have any issues, please feel free to reach out to me via email. I'll put my email in the chat just in case.
Well, thank you so much, Alex, and thank you, Dr. Maloney and Dr. Hendricks-Sturrup. This was such an amazing, fantastic, talk. And, there's so many different questions, but I'll reserve it because I have, access to speak to you. So, you might be getting, an offline question if that's okay. But thank you, and thank you for presenting and just, informing us the importance of data, but not just data, but just provenance of data and the metadata and the implications, because those data are actually owned by patients. And I think that is incredible. And that's really, centers around, our fifth vertical in the Department of Informatics and Health Data Science, which focuses on service, outreach, policy, and ethics. It's important that, yes, we want to be active participants in data and innovation and technology, but we must do so responsibly And as an academic institution, it is our duty, and I think it's one of the most sacrosanct duties and honors, is to better inform society and the population and to drive thought and action leadership around that. And you certainly sharpened the focus around those important areas. I know that, my good friend here, Dr. Rosario Isasi, she now is the director of our Ethics Institute, and I know she is going to be doing some excellent work. So stay tuned, not just to the Department of Informatics, but also our Ethics Institute as well. So thank you so much for being here. I know that we have an incredible next installment in January. Please look out for that. We have a phenomenal speaker, someone who is from the U. But I believe that you would absolutely love this talk because she is one of our leaders in AI education here, Dr. Lena Meadow. So you will love her. More to come in terms of detail, and we'll have some phenomenal speakers, for next year. On behalf of myself and our team, I wish you all a happy holidays, and we wish you a prosperous 2026. Thank you all so much, and see you at the next Health Data Innovation, the Future of Health Data Summit. Thank you so much. Have a wonderful day. Bye.